Okay, good afternoon everyone. I'm Gwynn Ginson. I'm an anesthesia nurse, and presently I'm working as a scrub nurse also.
Welcome.
Now, before I will start my lecture, I would like to thank Taiba Hospital for inviting me, and also to your clinical instructor, Mr. Chris, for facilitating the event. Okay, now, before I will start my discussion, you don't need to make some notes, because I have some handouts that I will be giving to you at the end of the lecture. And if you have some question, you can raise it at the end of the lecture also. Now, in between of the lecture, I will be raising some questions, and there are around 6 questions here, so I will be giving some prizes if you can be able to answer it correctly.
Wow.
Okay. Now, going back to our discussion this afternoon, pain, as we all know, is the 5th vital signs. Okay, and pain management is one of the fundamental and vital functions of a nurse. One of the interventions of pain management is epidural analgesia. And epidural analgesia is just one of the advancements of pain management. Now, nursing care for patients receiving epidural analgesia focuses on safely administering analgesia, achieving optimal pain control, and identifying and managing adverse reactions and or complications. Now, this presentation provides an overview of the nursing consideration of patients receiving epidural analgesia. Now, I will not be discussing to you this afternoon about epidural anesthesia. This is different. Epidural analgesia, though they are they are related. This epidural analgesia and epidural anesthesia. Now, also, I will not be discussing to you this afternoon about epidural catheter insertion and removal. So, if you have questions about that, then I might not be able to answer that. I will be only discussing to you about epidural analgesia. Now, let's come to the historical perspective first about epidural analgesia. Now, it was the Greeks who first used these narcotics. And then in the 1980s, they started to do this, to use these narcotics. And in the 20th century, this is the first time that they were able to use this epidural analgesia. Now, as you can see today, epidural analgesia is being used in different clinical settings, like for the cancer, for gynae cases, and urologic cases, and other many purposes of epidural analgesia. Now, let's discuss some of the terms that we will be using this afternoon. Now, how about analgesia? Analgesia is the absence of pain in response to a stimulus that is normally painful. Anesthesia is the absence of all sensory modalities. An infusion device is an external or implanted pump used to administer analgesia. Pain. Pain is an instinctively subjective experience that is multifactorial in nature and involves the interaction of physiologic, behavioral, developmental, and situational factors for the end response of all types of pain. Now, let me emphasize to you more about this term. Now, nurses' pain and patients' pains are different because sometimes nurses are interpreting or perceiving what the patient is reporting. So, for example, if you are heartbroken, if you have some heartaches, don't add what the patient will tell you. If he has 5 rate of pain, then don't put it 7, okay? And if you are too much happy, don't ignore if the patient is complaining of pain. How about epidural analgesia? Epidural analgesia is the administration of analgesic drugs like opioids and or local anesthetics into the epidural space via an epidural catheter, providing pain relief by bathing the spinal nerves as they run through the epidural space. It is delivered either by repeated boluses, injections, or by continuous administration of the local anesthetics. The infusion may or may not contain opioids into the epidural space via an indwelling catheter. So, first question. Now, all of the following are contraindications for epidural analgesia except A. Abnormal hemostasis, B. Localized or systemic infection, C. Increased intracranial pressure, D. History of laminectomy 15 years ago. So, anyone who wants to answer?
B.
Can you raise your hand so that I can, what is your answer?
Except
Other answer?
B.
Answer? C? What else? Except? Other answer? Your answer again? C? A?
B.
B?
B.
A.
B.
D. Okay, let's try to find out what is the answer. Now, here are the indications of epidural analgesia. Now, number one is acute post-operative pain relief, especially for, for example, LSCS, TURP, obstetric, this one, urologic procedures, and peripheral vascular procedures, and chronic malignant pain. So these are the indications of epidural analgesia. Now we have also contraindications. First is patient refusal. Then patient with coagulation abnormalities, infection at site of insertion, systemic sepsis, proven allergy to proposed drug use, uncorrected hypovolemia, and raised intracranial pressure. Now there are also relative contraindications. For example, if the patient has or is taking this low molecular heparin, okay, just like the Lexane. So there are contraindications, but can still be given as long as the patient will stop taking those medicines like aspirin or Coumadin, like few days before the insertion of epidural. So let's go back to the question. So what is the answer?
B.
B. So the answer is letter D. The question is, all are contraindications. This is except. Okay? So Chris has the first prize. Now, for post-operative pain, epidural analgesia may be the most effective medicine. This is according to Kingsley 2001. Now, there are clinical benefits of epidural analgesia. Now, those patients receiving epidural analgesia are the one receiving less drugs, but at the same time, the duration of drug is longer. Now, the outcome benefits is improved pulmonary function and gastrointestinal function, and shortened hospital stay. This is according to CME Resource 2012. Now, there are some disadvantages of this epidural analgesia. Number one is it requires competent practitioner for insertion and management. Another one is it requires competent nursing personnel for post-insertion care and management, and associated with very common common side effects and complications, and the effectiveness is somewhat variable. Now, the second question, an advantage of the epidural route is what? A, less sedation, improved pulmonary function. Letter C, longer duration with fewer doses.
D.
D.
Okay. What is your answer?
Sister Fatma.
Fatima. What is your answer again?
D.
Letter D. The answer is letter D. Now, I'm going to show you some of the position statements of the well-known organizations in the nursing practice. Usually they are the one issuing the standards of our nursing practice. Number one, these position statements are also related to epidural analgesia. Number one is, the nursing profession is committed to the provision of comfort and prevention of pain. As what I've said, this is one of the fundamental functions of nursing. One key components to the provision of comfort is the administration of analgesic medications. Number two, analgesic administration is within the scope of nursing practice and has been identified as an essential nursing responsibility. Now, according to American Society of Pain Management and Nursing, they believe that the administration of analgesia and the management of the associated effects are fundamental nursing responsibilities. They also believe that RNs, by virtue of their assessment, knowledge of the catheters and infusion devices, and the 24-hour presence, they are critical to ensuring safe and effective analgesic therapy by catheter techniques. Another one, according to the American Nurses Association and the National Federation of Specialty Nursing Organizations, RNs may manage analgesia, including re-injections of medication following establishment of an appropriate therapeutic range. Now, the reason why I showed you this position statement is to emphasize here that managing and taking care of patients with epidural analgesia, I believe, is within the scope of nursing practice. Now, maybe because most of the complaints of nurses is that they are afraid to touch patients with epidural analgesia. I don't know if it is happening also in your area. They don't want to touch, they want only the anesthesia nurses or the anesthetist to handle the patient. Even the machine, they don't want to touch because they are afraid to touch the patient and the machine and to care of the patient. Now, remember that patients with PCA or the patient-controlled analgesia is handling PCA. Yet, some of the nurses are afraid to hold the PCA machine. Now, see, for nurses, we are studying for almost 4 years, and we are having these trainings and experience to manage and care for different types of patients. So this machine is just one of the advancement of pain management that we should also incorporate in our nursing practice. Now, these are the 13 evidence-based strategies for infusion safety. This is an evidence-based practice. Like following policies, the hospital should have policies and procedures with regards to epidural analgesia, just like your nursing responsibilities. Ask for a pharmacist to review, confirm the order, use standard equipment and drug concentration, control the environment, know the use and the right equipment, identify the patient in at least 2 ways. I believe we have this practice, 2 or 3 or 4, okay? And the use of labeling system, and obtain an independent double check, like the order detail of the drug, the dose, the concentration, route, medication label and protocol, and also the dilution and syringe volume. And decide if you should give the drugs. You should decide for yourself. And then titrate the dose. And then check for adverse reactions. Be aware of the protocol to manage adverse reactions and report significant changes. Now, there are other considerations when you give this epidural analgesia. Just like you should not give butane IV. Okay, that might cause a seizure and cardiac arrest, and it can be fatal if you will give this butane IV. Lidocaine and bupivacaine is different, okay? And then the use some of the IV drugs, if you will give that in the epidural, can also be fatal. So that's why they are recommending a closed loop connection to the patient. That's why you should not give, or you should put the IV on the left side and the epidural catheter on the right side with the labeling, with the yellow labeling. That is the recommendation. And as what I've mentioned before, those patients receiving this Clexane, now you should not remove the epidural catheter 12 hours. Should be removed at least 12 hours after the last dose and 2 hours before receiving the next dose. Okay, question number 3. A well-conducted dual verification confirms all of the following except what? Order detail, medication label, patient diagnosis, programming, and any calculation.
Patient diagnosis. C. Dr. Soil, answer C.
Your answer is better C. Okay, it's correct.
So Mohammed Soil.
You took in head first, C.
Yeah.
Not answer last.
Now let's come to the nursing assessment.
What can I do? Hair took in first.
What are you doing here?
Now let's come to the nursing assessment for patients who are receiving epidural analgesia. Now for pain, what is the usual tool that you are using for pain assessment?
Numeric.
Numeric rating scale.
Okay, so we have numeric, we have visual analog, and we have verbal descriptive scale. And we have the you should assess that one every 4 hours. Okay. Every 2 to 4 hours, as long as the patient is having this epidural analgesia. The next one is the vital signs, the heart rate, the blood pressure, and the respiratory rates and depth. Hourly, this is to be assessed hourly. And how about the neurologic status? Now, there are certain tools that you should use, for example, for the level of consciousness. Now, one of the most used tools is the Ramsay scale. This is used for sedation scoring, Ramsay scale. Then we have also for motor tool, like for the movements of the legs. We are using this Brugage scale. Now I will be giving you handouts as what I've said, so you can have additional information later. And we have also this dermatome chart for the sensory of patients. Okay, so when you are assessing patients' sensory level, you should use the dermatome chart and this Brugage scale for motor and sedation scoring, which is the Ramsay scale. Now you should also assess epidural catheter sites every 4 hours. And the narcotic-related side effects. There are many narcotic side effects that you should always check for the patient if she is receiving this epidural analgesia. Now we have narcotic-related side effects. We have respiratory depression and oversedation. This is the most serious narcotic-related side effects. So you should watch out for this. And we have nausea and vomiting. Pruritus, which is the most common side effect. And hypotension. This is the second most detrimental side effect of narcotic. So let me summarize to you some of the nursing interventions that you should do in case the patient will have this kind of side effect. Now, there should be a naloxone, should be easily available in your area if the patient is receiving this epidural analgesia. You should have this, what is naloxone?
Reversal agent for
Antidotes.
Yes, this is the antidote for opioids. Okay, and we have also for pruritus and for hypotension. You should give what? What you are giving? Yes, epidural. And for nausea and vomiting. Yes, preperan and diazepam and chlorpheniramine for the antihistamine or for the allergic reaction. Now for the local anesthetic related side effects. Now we have bradycardia, local anesthetic toxicity, urinary retention, ascending blood, pressure areas, Now to summarize also the management of